That's where he is. I had a discussion with him on Tuesday night that said I really thought this was a better offer. And actually he disagreed with me, which was profoundly disappointing. But actually, in a broader sense, I think it's really good that they're beginning to think about mayors into that context, and particularly good that the South Yorkshire mayors appearing at those kind of events. So actually, I think that's a really good thing. Adrian, hiya, welcome. So I'm afraid you've got the reserve, the vice chair today. I've got a number of apologies. I'm not going to go through them. We will note them. I'm still expecting a number of other people, but the travel was a bit difficult this morning, certainly from Chesterfield, where there was snow, wasn't it? Never is, Adrian, never is. So I won't go through all the apologies at this stage. And remember, this is we've got the formal meeting first, then we've got our informal development session. And so I have to finish this on time. I'm under orders. And that also means I'm going to throw you out. I'm going to clear the room so people can rearrange it. So I will be rude when we finish to throw you all out, okay? Just giving you a bit of advance warning. Okay, any declarations of interest that we haven't normally had? Thank you. Minutes of the meeting on the 27th of September. Are they okay, those of us who were there? I think most of us were, actually. Any amendments people want to make? I'll take silence as assent. Okay. We have no questions from members of the public. We have a number of people online from the public who are listening to us, but we thought it was worth, normally at this point, Oliver would have given an update on some of the work he's been doing. I thought it was worth asking Stephen to do that. Stephen, could I kind of pass over to you for a bit of an informal?
Yes, you can, I think. And I think this is in part just that Oliver said he did want some things to be mentioned in the room, just to give you a sense that he's not sat on his bum not doing anything as MSCP chair. So just to give you a flavour of some sort of, this will not be comprehensive, any stretch of imagination, but there are a number of things he's been involved with quite recently, which I think is a reflection of the work of this partnership. And actually, his legitimacy obviously comes from him being the elected mayor of South Yorkshire, but his legitimacy in a lot of this space comes from him representing us as the Integrated Care Partnership chair. And over the last period, there's been a number of things which I think are worth sharing with you, where he's been actively invited, or has been doing work that actually either is in the furtherance of the strategy or actually is a demonstration of how South Yorkshire, in terms of this integrated care partnership, is actually starting to almost, dare I say, punch above its weight, or punch its weight, I should say, probably at the moment in time. So just a few things actually are worth sharing. The first one was, most of you will be aware that there is an emerging major conditions strategy, sort of shorthand of a government's response to early intervention and prevention, and that was published as a draft in April, and now has been knocked around significantly in the upper echelon sort of Department of Health and Social Care. And actually, it was fascinating to see the minister actually invite Oliver, amongst a small number of people, to come and talk about the content of that document. There wasn't anybody else. There wasn't any politicians involved apart from him. And it's interesting that actually the minister was inviting a Labour politician, but as the chair of the ICP, to come and talk through that. And of course, in his conversations, he was drawing very heavily from the work that we'd done in terms of the development of our integrated care plan. Secondly, Matthew Taylor, Chief Executive of NHS, conferred, specifically asked him to come and talk at a recent ICS conference that Pierce was at, and I'm very grateful for a number of colleagues in this room, including Andrew, that helped him draft some of the content. So again, he was back in for South Yorkshire and talking about all the brilliant stuff that's gone on and that we are doing, particularly under the banner of citizen engagement, and he's been actively supporting some of the work in terms of health innovation. And actually, know Sarah will be leading the discussion on the development session later on, but actually specifically meeting with some significant health sector, I can't say who they are because actually it's a bit confidential, but he's been starting to meet with some significant health sector, health and wellbeing sector organisations in terms of trying to think about them in terms of their role within South Yorkshire. And also has been actively supporting the work, for example, of a digital health hub, which we'll hear about later. And then there's the final thing, which Greg, who is on the call, has been contributing through. As you know, one of Oliver's key manifesto pledges and priorities, alongside health and growth and transport, was about doing politics differently, and he wants to stick a rock, build that into the work that he's doing. And so one of the things he's set up recently has been a citizens' assembly to draw upon representatives from across South Yorkshire who can talk about and comment on and reflect upon key policy issues. That's included climate change, but it's also included a session that we did last week around health, which Greg eloquently contributed to. So a lot of work going on, a lot of work that Oliver's involved in, and probably didn't want not to reflect that into the room today. Thank you, Piers.
Thank you, Stephen. That's really helpful. Can we move on to the next agenda item? And Greg, going to leave a discussion on smoke-free generation. Are you going to start, Greg?
Thanks, Piers. Yeah, so I will. I'll start. Sarah will finish off. Apologies, I can't be in the room. Major clash with homework diary. Time's short, so I'm not going to talk to the slides that have got my name against them, but I'll do some brief intro comments because I want to maximise time for Sarah to contribute and for the discussion that follows, which is clearly the most important part. So you've read the slides. I hope you've read the slides. Briefly, by way of introductory points, smoking is the the new
We've
smoking.
lost you a bit,
sadly
Greg.
for all of you, smoking is. Oh, how am I in and out, or is it gone?
It's okay now. You were in and out a bit before.
So smoking is the new smoking. Folk tell me X is new smoking, but no, smoking is. It will soon be overtaken by obesity, but for now it's fags. No other product, when used according to the manufacturer's instructions, kills half of its users anywhere in the world ever. Framing matters on this. This is all about the tobacco industry and its tactics and the interventions we use to counteract those. Vaping in kids, and there's some slides in there on vaping in kids, but do not let your focus go away from tobacco. That's where the harm is here. Most smokers start by 18. The regulation of the product matters. Sarah, who will talk next, and I mildly disagree on the effectiveness of interventions in schools to stop kids starting. The business end is regulating. If you wanted a single thing implicated in health inequalities, I would start with tobacco. We clearly frame it here in the context of illness, early death, NHS and social care demand. Equally, I can frame tobacco in the context of workforce productivity, age of onset of illness, UKP productivity, poverty. The amount of money that folks spend on tobacco is quite significant. Broadly, smoking is a good news story in South Yorkshire. Rates are consistently going down. Some of us do better than others. That is as it is, but the overall trend is downwards. But it still is the main cause of early death and early onset illness of many types. Cancer, cardiovascular disease being the two main, but respiratory disease. You look at your burden of disease, smoking is implicated in a very large chunk of that. But all that said, the good news story, the rates are coming down. That is not happening by magic. It's happening because we're consistently doing the right thing decade after decade after decade. And if you want to see an example of success story in public health, look there. There are a few others, but this one is a good one. This government in recent history have been quite active, to their credit. I think slide 4 talks from April 23. Government announces on government announcements on smoking and vaping, stopping the growth of vaping in children. There was a call for evidence, introducing new help for a million smokers to quit, incentive scheme for pregnant women, etc., etc., etc. So and government the minister of the time, Neil O'Brien, was very personally committed to this agenda, and government very active. The big tilt was a month or so ago in October 23. The proposed legislation to raise the age of sale. Just one critical bit of framing. This isn't about making it illegal to buy cigarettes. It's about making it illegal to sell cigarettes to children. So children turning 14 or younger this year will never be able to buy legally. Will never be able to be legally sold cigarettes. that announcement, and there was a bunch of other announcements in there, which I'll come on to. One was a surprise. No one saw it coming. Two, the Prime Minister's put a lot of personal political commitment onto that, and I think he deserves enormous credit for that. Three, it's probably more important than the ban on smoking in public places, which was 2008, and that was the single most important piece of public health legislation in the 20 years previous. This is big, probably bigger, and it will save more lives than any of the actions of all of the people in the room today, and me included. However, it isn't secure yet. It isn't the law yet, and I encourage you to watch what happened in New Zealand, where we've copied New Zealand, and New Zealand have just rolled back. So your responses to the consultation and your interactions with MPs matter a lot on this, because it will all boil down to votes in Parliament, and the tobacco industry are going all out to put a stop to this one. Because if it happens here, it will happen elsewhere in the world. So tobacco.
You've gone a bit there, Greg. You went in. Go on.
Yeah, tobacco industry are out in force on this one. So the vote in Parliament matters, and matters a lot. So your interactions with MPs, your consultation kind of really matters. There was a number of actions to tackle youth vaping, which are on slide 6, and I'm not going to dwell on them, but basically we treat vapes like fags. It's a consumer product, and we're going to heavily regulate it, or the proposal is to heavily regulate it. I would propose we don't have a long debate today about youth vaping. It does matter, but the tobacco end, the tobacco is the business end of this discussion, and we need to let that at our great peril. Lastly, there's new funding. That money is welcome. I think I'd encourage the NHS stakeholders to think hard about the long-term plan monies, because if NHS England go back on the long-term plan monies in tobacco, we turn it all into a zero-sum game. We don't get any extra additionality here. The new OHID money from a local government perspective will be committed to a mix of stop smoking service and tobacco control, and enforcement is absolutely critical in that one. So just by way of me and next steps, then I'll hand over to Sarah. The consultation closes soon. If you haven't contributed your response to it, please do. It is not a secure piece of legislation. It's a fundamental piece of legislation. The tobacco industry are out in force, and they're pushing hard on this one. I'm now going to hand over to Sarah, that's going to talk you through a proposal to do as much as we can with the additional funding in a South Yorkshire tobacco control and smoking cessation context. So, Sarah, over to you.
Thank you, Greg. So are we now moving on to agenda item 6, effectively, Sarah? Yeah. Just so I know where I am on the agenda. I'm a simple man. Thanks, Greg. Thank you.
Okay.
Great. Hi, for those of you that don't know me, I'm Sarah Hepworth. I'm a health improvement principal and I lead on tobacco control for Sheffield. So I'm going to talk to you today about the international evidence base, the regional evidence base, and we're going to look at this from a South Yorkshire and place-based perspective. Leanne, do you want to introduce yourself?
I'm Leanne Sparks. I'm Senior Prevention Programme Manager from the ICB. Predominantly have oversight of the QUIP programme.
Next slide, please. And we just need to go on a little bit more and then we'll have caught up. Next one. Okay, so in terms of the international evidence base, there's strong evidence around what we need to do to reduce smoking prevalence and to deliver comprehensive tobacco control. Essentially, it's the World Health Organization MPAL model that you can see on the slides there. So it's stopping the promotion of tobacco, it's making tobacco less affordable, it's effective regulation, as you've just heard Greg say, it's helping tobacco users quit with our stop smoking services, reducing exposure to secondhand smoke, and that includes smoke-free public places, and it's effective communications, all of those things, and they mirror through the previous slides and what the government are proposing to do and what we've done locally, nationally and internationally. And the reason for this is we need to impact on all of the factors that influence people to smoke. So the social, environmental factors, the economic factors, and we need to think about how we can best prevent children from starting to smoke and also support people effectively to stop smoking and cause friction in that. And we've done that effectively. So moving on to the next slide, please. So a week ago when I wrote these slides. You can see how things move very quickly in tobacco control. So New Zealand and Australia have always been leaders in this space, and actually the prevalence in New Zealand is currently at 8%, so they're doing phenomenally well. Unfortunately, a political change in government, we're not going to follow suit, we're not going to be following them, but they have been leaders in this space, as have Australia. Next slide, please. California also, not the US in total, but California have implemented really comprehensive, stringent tobacco control measures, and they've seen prevalence come down to around 8%. So again, really strong evidence where they've moved faster than the rest of the world. Okay, next slide, please. This is a map of the regional tobacco control programmes, and the orange sections are where we've had faster declines, the way we've had more investment and where we've had regional programmes that have worked more collaboratively. You've seen that reduction again at a faster rate than other areas. Okay, next slide, please. So what we do know, so ASH of Action on Smoking and Health UK have helpfully put together the evidence base in one document here. And they basically outline key areas where we can get the most bang for our buck in terms of effective collaboration across a regional footprint, but also a wider footprint such as Yorkshire and Humber, so South Yorkshire and Yorkshire and Humber. So working on illicit tobacco, comms campaigns, effectively writing business cases to support ourselves so we've got a consistent approach, policy, so that could be smoke-free policy, e-cigarette position statements, and then also facilitating developing local approaches, so that could be around access to stop smoking services and ensuring equity. We've got evidence-based models, so Fresh in the North East, London, Manchester, Humber and North Yorkshire. We've got examples where they've driven down prevalence at faster rates than other areas. And this is on top of what we're doing at a local area, so it needs to complement what we're doing at a local area. Next slide, please. Okay, so there's a huge amount of activity going on already across South Yorkshire in our place-based areas. And this is the list really of what we came up with together in terms of, we've all got 4 tobacco control boards, we've got commissioned stop smoking services, and we're looking at how we align that offer. Doncaster and Sheffield are working to the same specifications, and we're looking at how we can roll that out again in other spaces. We've got a vulnerable people strand, which is about us working more collaboratively with our most vulnerable people in terms of homelessness, substance misuse. We've always done work in these spaces, but it's how do we make it a strategic approach across the piece? Smoking and pregnancy services, enforcement action we have in each of our places, but we collaborate on intelligence. Smoke-free public places, we're looking at city centres, what can we do collaboratively so that we learn from each other and take that forward. We've then got QUIT, which now I'm going to come on to talk about, so I won't do. Commercial determinants of health, really, really important, where we've worked together around guidance on festivals and also Keep Britain Tidy. This was where the tobacco industry were actually fronted by Keep Britain Tidy and wanted to have smoking places, and you can imagine how I felt about that, smoking areas across, it was in particular in Sheffield and Doncaster, and we were able to prevent it. And yeah, so that collaboration really helps because we can see what's coming on board. Harm reduction, youth vaping, we've collaborated effectively in terms of the communications campaign and supporting schools across the system. And we're currently working on a comms campaign, which I'm going to come on to in a moment. So we've got informal structures. There's already a lot of collaboration there. If we were to look at how we could emphasise that and really grow that impact, it would be looking at staffing resource and financial resource. Okay, next slide, please. We've got a track record of success. We are renowned across the country, both at Yorkshire and Humber, and at a national level in terms of our success. Doncaster, just a few months ago, had the first custodial sentence for illicit vapes, which is phenomenal. The actual business owner got 8 months. They're leading on a vaping and research project within Doncaster, exploring young people's views. Barnsley have got their stop smoking services rated the 2nd best nationally. So again, we've got really strong evidence of good practice. Rotherham are looking at, they've currently developed their action plan. You can see the 5 areas of focus, but they're also looking at how they can redistribute funding and looking at more enforcement work. So again, thinking what else is next? What else can we do? Next slide, please. So in terms of, I want to talk about Sheffield and where we were, really taking you back 5 years ago. Our rates are currently down to around 12%. They've not always been at 12%. We've seen significant success since 2017, and that's 20,000 fewer smokers. And we're currently the 5th best in Yorkshire and Humber in terms of smoking prevalence, and we're the lowest prevalence of the core cities. And back in 2017, we just had a stop smoking service, and we did some interventions around wider tobacco control work. And we knew we needed a game change. We needed to shift. Next slide, please. So, sorry, this is just demonstrating pictorially where we are in terms of the core cities. Nottingham is at the other end of that. We move on to next slide again. So, in terms of where we were in 2015-16, we were focused on individual 4-week quits. People were nervous to come to the board and felt that it was more performance focused. They felt that we weren't looking at solutions. They felt that we were silo working. They felt that it was focused really on so there was gaps in who we also had around the table in terms of university, voluntary sector reps, and we were very NHS focused. We weren't looking at the totality of what we could deliver. 90% of the funding was invested in stop smoking services. Next slide, please. So we made a bold move, and I have to say a move that you wouldn't make, and I did have a little bit of, Greg, will you sack me if this doesn't work? But looking at the evidence base, we knew it was clear we needed to deliver wider tobacco control. So what we did is we redistributed funding so that we could deliver action on communications, a whole school approach, smoke-free spaces and trading standards, so more enforcement work. And that's what made the difference in terms of this. So we still had a stop smoking service. Stop smoking service is incredibly important, but they can't do it by themselves. They only ever have 5% of the smoking population coming to stop smoking services. So what do we do about the other 95%? We have to have the range of other measures in place that will influence those people at population level to quit. Next slide, please. I'm sorry, you really can't see this. This is our plan on a page, our tobacco control strategy within Sheffield, which is essentially the WHO Empower model at a local level, delivering comms and marketing, enforcement action on trading standards. We've delivered smoke-free spaces work, so that's all of our public sector institutions going smoke-free. We're currently working with Sheffield University and Sheffield College to get them to go smoke-free. That's externally on their grounds. Sheffield Hallam are. We are pro-harm reduction. We've done a huge amount of work on vaping in children and young people. So whilst obviously we support for adults to switch to vaping, we absolutely do not support. There should be no marketing to children in any way, shape or form. We've got a midwifery stop smoking service, an incentive programme, and we have a smoke-free service for adults that prioritises our priority groups and high prevalence groups. Next slide, please. So in terms of what worked, we had to change the way that we were doing things. One, in terms of the model, but also in terms of how we worked collectively with the board. We needed to become bigger than the sum of our parts. We were working far too disparately. So this was down to strong public health leadership, looking at Greg and I having open and honest conversations with board members around what was working for them, what wasn't. It was also looking at empowering each other to collaborate and develop that ownership. It was consistent support and expertise from myself, from Greg and others. And sometimes it was about pump time money. So in some cases, we would, for smoke-free spaces, we would give a small amount of money and that would be match funded. And that made the difference. And also it was powerful that the DPH had asked for that as well going forward. Adopting ongoing test and learn, not wait until the end to refine things. If things weren't working, being brave enough to fail was really important. And looking at the evidence base again, constantly scratch my head about mental health and pregnancy. What else can we do? And seeing what works in progress. And that really motivated the board and the staff. So you're going to hear from them next. Next slide, please. Oh, you're not. So you're going to see what's happened in pregnancy. So through our successful collaboration in pregnancy, we delivered a mini tobacco control programme. So that meant that the site went smoke-free. We developed training videos that were consultant, midwife videos. And then we also developed this comms campaign, which is the picture that you can see on the very right there, floor vinyls, demonstrating the benefits of stopping for women and the risks of continuing to smoke in pregnancy. So that whole system approach within one setting as well is really important. Next slide, please. You'll have to click again. These are just some of our campaigns that we've run. All of our campaigns are about compassion and hope and encouraging smokers to try once more. Smokers already feel stigmatised. They're already feeling marginalised in society. It's really important. We can't bash people into making those decisions. We absolutely need to show how supportive and that we care. Smoking doesn't care about you, but we do. Next slide, please. This is just some of the work that we've undertaken around smoke-free homes, smoke-free public places, and some of the seizures that we've done, just to give you an idea and flavour of that work. And this can all be found on the Smoke Free Sheffield website if you wanted to look later. So now you're hearing from the board members. This is a variety of our board members talking about what the board means to them and why they feel we've been successful. And just to paraphrase, Helen, our consultant midwife, feels that it's that we always strive for excellence and innovation. And Joe Lesage, the Healthy Oscar Programme Manager, is saying, you know, it's about the strong partnership at a system level. It's a true system level approach. Emma Hock, the scientist from Sheffield University, is talking about here how we take the evidence base and we apply it at that population level. And Jenny really feels that we've got an inclusive approach. In terms of Moira, I think this is probably my most favourite quote in terms of we've become the sum of our parts. You really don't see the disparateness within the board of 45 partners now. You know, you see that we'll have a session on smoking in pregnancy. Everybody's there. Trading standards are thinking about what they can do, as well as the midwife. And that's the same when we're talking about mental health and others. Next slide, please. So this approach, we actually won an award for our tobacco control programme earlier this year. The Local Government Chronicle Awards for the collaboration and comprehensive programme that we deliver and driving down smoking rates at a faster rate than other areas, which we're really proud of. And it's down to the consistent leadership and constant not giving up, really. We're very, very tenacious, as we all are. And I think the quote here for me, we've come full circle in terms of Deborah Arnott in 2017 called us out in the press and said, what is Sheffield doing redistributing this resource? And thankfully now we're working really closely, and she's got you know, she's putting us up there in terms of best practice model. Next slide, please. So we're going to talk now about the QUIT model, then I'll come back to some of the South Yorkshire work.
Thank you, Sarah. So, yeah, I'm here to talk to you about the QUIT model. Now, back in 2019-20, Yorkshire Cancer Research and the ICS, as was then, developed a model to deliver tobacco treatment in all of our acute and mental health trusts. Business case was developed. Richard Jenkins was around even at that time. And I didn't mean it.
Clearly, you're very old. Can we just agree on that?
I didn't mean I meant with the programme, not on the planet. Apologies. So business case was developed, teams were ready to go, but then COVID hit. Chief execs across the system still kind of gave their commitment to the programme at a time really of unprecedented pressure for the NHS. So why did they do that? Well, the why column there really is exactly why they gave their commitment. So 20% of deaths across South Yorkshire are linked to smoking. It's the single biggest cause of preventable deaths, disability and illness. It's the single major cause of health inequalities. It makes business sense. We spend over 26 million on smoking related admissions. And fundamentally, treating tobacco addiction is the single most cost-effective life-saving intervention the NHS can provide. So what have we done? Well, this year, as Yorkshire Cancer Research funding has kind of petered out, the ICB committed £1.8 million to the QUIT programme to continue the development of the service from the health inequalities pot. As a result of that, we now have pathways embedded across all of our trusts. Our pathways see people screened on admission, offered specialist support. Crucially, we then offer an onward referral to our community stop smoking partners who are commissioned by our local authorities, but work really closely and collaboratively with our hospital teams. Our pathways really provide an opportunity for what Sarah was talking about in terms of system-wide working, with a real opportunity for seamless transition between our services. Importantly, in the final column, what have we achieved so far? Well, I've mentioned that our services are in place. They're in place ahead of the NHSE deadline of March 24. That's due to the additional funding from the Yorkshire Cancer Research Team and the ICB's Health Inequalities Pot. But a few figures outlined here. In Q2 alone, we have screened over 85% of eligible admissions. That's over 22,000 people being asked their smoking status. Once a person's identified as a smoker, our teams will provide a specialist assessment. A specialist assessment is a discussion with a trained advisor who will talk to them about smoking habits, motivators and methods to quit, and make a recommendation on NRT. Our teams have conducted over 12,000 of these specialist assessments, and that's conversations at the bedside that wouldn't otherwise have been happening. And like Sarah said, 95% of people aren't going to stop smoking services. So this is an opportunity to reach those people who otherwise aren't traditionally opting to go to stop smoking services. And the final bullet point there, since July 21, we've achieved through the QUIT programme over 1,900 4-week quits. Evidence suggests that for every two people you get to stop smoking, you save a life. So that's 950 lives saved, absolutely black and white. Next slide, please. So continuing on the theme of impact, but with the added lens of health inequalities. So NHSE have developed their tobacco dashboard, where every trust is required to submit data in relation to their tobacco treatment services. These charts here are specifically for South Yorkshire and are specifically our inpatient and mental health trusts. They look at deprivation quintiles taken from patient postcodes, and as you can see across each step of the pathway, so patients identified as a smoker, patients seen by the in-house team, patients then given a care plan. The populations or the individuals from our most deprived communities represent well over 50% of the people that our teams are seeing. So with confidence, we can say that our delivery is reaching those people who are experiencing the greatest health inequality. Next slide, please. Next slide, please. Is this all right? It's frozen. Great. So I've talked about data, but these stories really are the real impact. So on the left, we've got a service user from Sheffield Health and Social Care. He's smoked cannabis since the age of 15, cannabis and tobacco. QUIT team at the Care Trust engaged him and provided him with 12 weeks of support to get him to a smoke-free status. Now we know the health inequalities that people with mental health conditions experience are far exacerbated, which is why this case study is a bit of a favourite of mine. You can see at the bottom there, he's joined the gym, he's got his taste buds back, he's enjoying his meals. So the many benefits to his health and well-being that just can't be captured in data. Similarly, he's got some of his friends off cigarettes. So again, the ripple effect of our work is just far and wide. And then on the right, for transparency, I must declare Bazzi is very small, and I know of Jay's daughter through a previous role, and we'd had conversations that she was desperate for her father to stop smoking, but she could never see it happening. That was until he came into the hospital and met the QUIT team, had a conversation about his smoking, spoke about better ways to quit, his NRT usage. All of those tools gave him the confidence and the skills to remain smoke-free post-discharge. And safe to say, my friend's a massive advocate of the programme as a result. Next slide, please. So we're having an incredible impact on lots of smokers across South Yorkshire, but there's lots of work to do. I won't talk to every bullet point, but in order to continue having the impact that I've outlined, we really need to maintain that system-wide support and commitment to the programme. A key focus of mine over the next 6 months is to review the interface between the trust and community services. We've got support from our local authority commissioners, which is great, and the teams themselves, to really ensure that what we're doing everything we can to make that transition as seamless as possible for our patients and residents. Primary care is a key opportunity. We want to raise awareness of the programme amongst primary care colleagues. I think for me, confirmation that we've delivered a kind of real system culture change programme will be when we've got patients coming into hospital and saying, hey, where's my NRT? I'm expecting my NRT while I'm in hospital. And finally, aligned to further promotion within primary care, we want to utilise the newly developed Smoke Free Starts branding, which gives us an opportunity to unify smoking cessation messaging across South Yorkshire, which leads me very nicely back to Sarah, who's going to talk to you about how we want to work together moving forward. Thank you.
So this is the really exciting bit. So in Sheffield, we were looking at developing a mental health and smoking campaign. And then the opportunity came for us to collaborate further across South Yorkshire. The ICP had put some investment in to tobacco control already. And what we did, so the tobacco leads plus Leanne, we came together to discuss, well, how do we take this forward? And one of the first things we started to talk about is what's our brand, what's our identity? And it became clear we needed to really focus in on that and look at what our values are and what it is we're trying to achieve. And this is the result of that work, because what we do need, in order to be unified, we don't want 4 logos from local authorities plus the ICB, and the logos become bigger than the campaign. So what we've got here is Smoke Free Starts, and the idea behind this is obviously we're all working to achieve to make smoking obsolete, to achieve the government's ambition and get to 5% or less. Smoke Free starts with us. Smoke Free starts with community. Smoke Free starts with family. So it works for prevention and it works for here and now. So it's got many, many different aspects that we can use in taking this forward. The colour palette green is about go. So thinking about, go for it, try again, really trying to build on those aspects as well. And the arrow that's in starts, you can see it's directional. It's saying this is for you. So it says a lot within a small space. So I'm going to talk about the smoking and mental health campaign. Sorry, next slide, please. So we've all got high rates of smoking prevalence, unfortunately, across mental health, particularly with our people that have serious mental health conditions, depression and anxiety. And this was where we felt we could make the most bang for our buck. So we're focused on our audience is 18 plus, people living in the most deprived areas, social housing, people who are unemployed on social benefits, low paid, shift workers, routine and manual workers. They're where we've got the highest smoking prevalence and where there's the highest prevalence of mental health conditions. So we know again that will be really effective. Next slide, please. In terms of targeting. So our aims and objectives of this campaign are to increase awareness of the impacts of smoking on mental health, to increase awareness of the benefits. People know about the physical health benefits, but they don't know about necessarily the mental health benefits. So smoking cessation is an intervention in its own right. It reduces anxiety and depression, and it acts as an antidepressant. We know that people think that smoking helps them cope with stress. It's actually the opposite. It exacerbates symptoms and makes things worse. And there's a biodirectional relationship. Getting that into comms is going to be really easy. Really can't wait. So we're doing that bit. So between smoking and mental health, in terms of onset of smoking, mental health illnesses, and then also exacerbating symptoms. So there's a lot to say. We can't do it all at once. We're focusing on these things. So myth busting, very much so, in terms of also the stress and anxiety that people feel is often down to withdrawal symptoms. So there's a misperception there as well. So the idea is that we dispel the myths, and we're looking at increasing the number of people that quit through our services, but also at a population level, and working closely across the partnership. So we've undertaken some insight work already, and this has confirmed, unfortunately, what we believed. 43% of people in South Yorkshire believe that smoking can improve stress levels. And 57% believe that smoking can improve mental health, impede their ability to quit smoking. So we know, first of all, what we've got to do is take people forward in terms of awareness raising. We won't be able to go forward and just do one thing. So we're doing a radio advert, we've got social media, and we'll do target interventions, and we'll do lots of case study work as well. And that's where we'll get that effective intervention. We'll be working with health professionals, and we'll create resources for health professionals. There's further tranches of this as well. Young people, certainly 15 to 17-year-olds, perinatal mental health. So this is the start of it, really. What is really exciting is it's the first in the country, and Action on Smoking and Health want to work with us on this, and Professor Anne McNeil. So this has got legs beyond what we want to do here, which is fantastic. Next slide, please. So we'll come back to the campaign in a future session if you'd have us, and present to you how we've got on with that. So I think you'll need to click again in terms of this one. So this shows us the gravity of the challenge. Currently, around 30% of smokers are making a quit attempt. That isn't going to get us to 5%. We need 50% of smokers to make a quit attempt every year at a population level. Next slide, please. So we've got around 150,000 smokers in South Yorkshire, and we're looking at an 8.5% reduction. So that's just at adult level. That's not looking at inequalities or our high prevalence groups. That means we need 75,000 people a year to make a quit attempt. That is a huge ask, and that's why we need this commitment at both a national, regional, and local level. We're not going to achieve it if we don't have those things in place. And just again, the point of we can't do it all through stop smoking services. Next slide, please. So what is the role of a regional programme? And I think we do lots of things collaborative across South Yorkshire, so this will be no different, but it brings together the resources and expertise. It enables us to coordinate activity, it enables us to avoid duplication, The consistency of approach is really helpful. It certainly has been in terms of the vaping and young people resource and ensuring we get the facts straight and we've not got myths out there in terms of or misinformation, aggregating skills and expertise to drive effectiveness, different funding streams we can apply for different pots, and also it enables us to be stronger in our voice. We've certainly got more power in coming together. Next slide, please. So collaboration adds value. I think, again, I'm sure you're all aware of this, and the effectiveness of what we can do. Working at that larger footprint means we can enhance local delivery. And we've got, going back to the evidence base, examples of where this has worked, both in terms of Breathe and Fresh and Manchester across the country, where they've effectively done this. Next slide, please. Strong, consistent leadership is critical. In-depth knowledge of tobacco control, the evidence base, the political climate also. That engenders trust, collaboration, innovation, and that collective voice is what's going to lead to success. Next slide, please. So this is absolutely true. The tobacco industry, you know, they are a mammoth beast, and working collectively is our superpower. I talk a lot in the tobacco board about relationships really are our superpower against the industry. We know they're out in force at the moment. They like to, you know, the way that they conduct themselves on a continuing never ceases to amaze me. But they will lie, they will cheat, they will do everything they possibly can to collude, and they will spread misinformation. So we need to do this together. Next slide, please. Ultimately, the end goal for all of us is the future without tobacco. This is my dad. He died in 2020 of smoking-related illness, and I've been passionate about smoking for a long time, but that just drove me to be even more passionate. And we all want a future where we don't lose loved ones, and we certainly don't have children starting to smoke. Next slide, please. So our ask of you today is to endorse a South Yorkshire system level approach to tobacco control, and to endorse us developing a business case and taking that through and looking at the different aspects that we will need in terms of financial investment, staff and resource, and governance at this system level, and what existing partnerships we can build on. Thanks for listening.
So that was great. Really, really powerful stuff. And I learned a lot of stuff. One of the things that just picked up me, if I could start, one of the things we're thinking about as an ICB generally is also seeing our staff as part of the population, as opposed to just, and if we're particularly focusing on mental health, are we doing that with mental health staff as well? Because actually that whole role model thing is, I would have thought was important just instinctively. I'm sure it's been picked up, but we are beginning to say to ourselves, our staff are also our population, and we need to be confident that we've got that bit right, rather than the population's over there and our staff do it over here. Because they're the same people. It's 100,000 people if you include social care or whatever it is.
And also we need to make sure the offer for staff is the same as the offer for our service users, because often we've got a kind of token offer for staff. I've felt in the past we're doing a lot to level that out, and through the QUIP programme and also through the services, staff can access the same support.
Any questions for people? Helen.
Thanks, Sarah and Leanne. I thought that was great, and I think it's really important work. And I know from Sarah what great work you do in Sheffield with communities. I'm really interested in the sort of level of nuance that you get into, and I think the myth busting work is showing that you're trying to understand people and not starting from the kind of systems and services, and I think that's key. I think the prevalence of smoking in communities affected by health inequalities could be a proxy for a whole range of things around deprivation, and I think it would be really interesting to understand what are the other reasons that people are smoking, and what level of detail you've managed to get to, or if that's something that you'll be able to kind of get to at some point. My feeling is that some of those reasons are not within the reach of the health and care system, and do we want to use that as an opportunity to push for other policy and decision making agendas to kind of accept some responsibility? So yeah.
So there's a range of reasons, obviously, why people continue to smoke, and some of the biggest factors, I think, particularly around the cost of living crisis, stress, and the belief that given all of what I've got going on now, it makes it impossible for me to think about stopping smoking. So it's our job to show people what's available in terms of the stop smoking services, but also that people like them have quit through our services, and this will improve their lives and support them. So that's one of the things that this campaign will do as well. It's important, really critical.
Yes.
Yeah, hi. So I'm Rotherham Medical Place Director. Sharon Kemp, who's the Chief Exec at Rotherham, and Ben Anderson and Councillor Roche, they couldn't be here today, but we have had a pre-meet and they are very happy to endorse your plans going forward from a Rotherham point of view. So just to say that, thank you.
So I think there's been requests through Pop Health Management, Health Inequalities SDG that I chaired for a regional approach on this. I think if you look at some of our neighbours, we think that's a good way. You know, we can learn from each other. We can, you know, put our resources together. So I think yeah, absolutely behind it from an ICB and Chief Medical Officer point of view. I suppose there is just a question to the board today: is are we willing to sort of pool some of our resources to do that? So there's new money that's coming down. You know, I know there's priorities in each of the individual places, but you know, we don't have the luxury. We're at a point in time where we've got this legislation, which is absolutely key, as Greg highlights. You know, can we make a commitment? That's the question I'd put to the board. Can we make a commitment to, you know, maybe use that in a more collective way? Thank you.
Yeah, I think we should be asking place and the local authorities, can we work collectively on this? Because this does appear to make it's about making the biggest difference here. It's not about, I want to do it better here. It's about, I want to reduce smoking and what's the most effective way of doing it. So we'll pick that up with all the places and with the local authorities. If that probably would help, David, if we do that. I don't sense any reluctance, but we might need to just push that and make sure we do. Any other questions? Gavin? And then Kathy, sorry, Kathy.
Yeah, it was, I mean, thanks, Pierce. So it was just to support that request, really. You know, clearly reducing smoking is a very specific ambition within our integrated care partnership strategy. So I think a collective approach, we've already made that commitment collectively, so a collective approach makes a lot of sense. Just a couple of points. One was a really obvious one about the government consultation and just checking that we have collectively and severally responded to that. I'm a bit anxious because of the New Zealand change, and this is just a terrific opportunity we can't let slip away. So not to be answered, but we just need to check that we've done that. I think my third point was the 150,000 and the, you know, can we get 50%, you know, to attempt to quit. It seems to me that there is a sort of a bit of an analogy with vaccination. So, you know, there are groups like our own staff or people who access our services that through programs like Quit that we can access in that way. But there are also you know, parts of the community that may be more difficult to access, and how do we use other partners, the VCSE particularly. And that point about the myths, I mean, that seemed like a real kind of resonates with some of the challenges we had over vaccination. But actually, if we could address some of those myths, and to do that, you need trusted people who are trusted by communities, and I think that's where the VCSE could come in. So it was just to say, it's almost like, you know, if we're going to go for that 50% of the 150,000, it's like having a kind of laser-like approach. It seemed to me that there was an analogy. Thanks, Chair.
Let me just pick questions. I've got some online. So Nigel, and then Richard, and then Greg. Nigel, nice to see you.
Yeah, I mean, just from Doncaster's perspective, I mean, I think there's a strong broad agreement in principle in terms of obviously supporting it and the very, very good work it obviously does. I mean, from our perspective as a local authority, we just need assurances and strong assurances, effectively, that it was data led in terms of obviously the current figures being based around numbers and areas of deprivation. As we're all aware, I mean, we've all got within South Yorkshire, you know, certain areas of deprivation. But we would like assurances that obviously Doncaster, from our perspective, is going to obviously sort of like, you know, benefit from this.
Thanks, Nigel. Richard.
Thank you. Yes, it's a quick SRO. The QUIT program's been a very complicated one to do, but just to pick up your point, Pierce, one of the 6 aims of QUIT was about staff. So we recognise that staff both, you know, we've got interest in keeping our staff healthy, but also their staff can then become advocates for this programme, both in their communities and with their patients. So far, QUIT's been focusing on inpatients, which is for a sort of standard DGH, might be about 40,000 people getting admitted a year. But we'd probably be seeing about 250,000 people in outpatients a year, 100,000 people in A&E a year. And so looking to see what we can do to increase the reach of quit is something we'll be doing as well. One of the things I've sort of been troubled about over the years, seeing how the smoking cessation work's been going, is how do we reach the most deprived populations? Because I think the data is, I think I'm right in saying that the data so far on smoking reduction has been, the impact has been differential across the different deprivation groups, and least there's some groups we haven't been able to reach, and I think it's very gratifying that the QUIP program seems to be reaching some of the most deprived people, and therefore having that benefit there too.
Thank you, Richard. Greg, and then I've got Kathy. Greg.
Thanks. So in reverse order on reach, yes, we broadly are getting to the most deprived populations because those are the groups left smoking. So we've inequitably addressed that over the years, but we're now at the difficult end of the market, the very, very, very addicted end of the market. So our progress will be kind of in that context. On footprints, I was just going to make some comments. This has to be built on local. So each of the 4 areas have something akin to a tobacco control board, which is very functional and works really, really well. The proposal is to build on that and to do the things it makes sense to collaborate on, largely built on the Fresh model in the Northeast, which has been established for decades probably, which it doesn't make sense to do sort of media campaigns at local footprint. They're just the buying power and the ability to reach. So there are some things that we'd want to do regionally, ditto regional approaches to trading standards. So we're building on that model. So this isn't an or and, this isn't an or, this is an and, local and sub-regional or maybe regional, picking up on David's point. And the last thing, Piers, just picking up on your point, I would be astounded if the 4 health and wellbeing boards haven't already robustly responded to the consultation. I know for a fact Sheffield has, and I'd be astounded if the others haven't as well. More consultations from more stakeholders, individual and collective, will matter. The weight of the postbag really matters on this one. And I know for a fact there are tens of thousands of copy and paste comments that have come in from tobacco industry stakeholders. That matters. So countering some of that. But it all boils down to the vote in Parliament. So making your views known to your elected representatives really, really matters on this one. And I'd encourage us all to do that individually, professionally, collectively, institutionally, and in any other way.
Really helpful, that, Greg. I felt guilty. I haven't written a personal letter and I need to do that. And that's the kind of stuff until today, I wouldn't have picked that up. So actually, I think that's really important. I think I can say this. We do have some Conservative MPs as well in the patch. It's really important they are written directly to. There is something about preaching beyond the church. And actually, they need to feel, I don't mean to sound unkind, they need to feel the pressure, don't they? And it's really important that we make them realise how important we think this is, how important it is to the health of our population. Kathy.
Sorry, I wonder would it be worth actually getting a bit of a draft letter that we could share and circulate to put that pressure on our MP. It'd just make it a bit quicker in the process, I think, for the health and wellbeing boards. I suppose I'm interested in, Greg has touched on it, the 12% who are still left, who are probably at the intractable end of the spectrum. And I suppose I'm interested in what you know about that 12%. And then also I was interested as well that you're looking at behavioural economics, particularly about how you work with that 12%. Because we're doing a piece of work with the Pathways to Work Commission, where we're saying is how do we make sure that services are designed not based on what people need, i.e. what we think they need, but on what people want. So how do we tap into people's desires, drivers, motivations as well? And I think there's something for me in the campaign about how we make sure that it's based on lived experience and personal storytelling, because if you can't change people's emotional connection to tobacco, you're not going to change the behaviour. So I think let's maybe try and do that collaboratively. Andy probably has some ideas on that, and lots of other people. Really happy to kind of help with that, because we've done a lot of that work around skills in Barnsley as well.
I was just going to come in quickly for Doncaster. Sorry, I joined late. I'm Rachel Leslie. I'm the Acting Director of Public Health at Doncaster Council. So yes, we have written to our 3 MPs, including our Conservative MP. I know that Sheffield definitely have as well, and I very much expect that the other councils have. So we have the letter that we're very happy for you to share and use. That's been signed by various people, including the Mayor and the Chair of our Health and Wellbeing Board. So that's there.
On that question and point of regional versus local, it is the and. So those funds come into local authorities, and I expect that each area will have some really good ideas about what they want to do with that, and the networks are established about what our different smoking leads learn from each other and how they apply that too. It's probably just worth recognising that those smoking cessation services and offers will be different in each local authority area. Part of the terms of receiving the funds is that we have to maintain that investment, which is a really good thing. But there might be some areas that might need to do a little bit more of what they've not been able to do previously in order to be there. But yeah, I think both things, making that judgment of what our local investment needs to be, additionally for that local based focus, but also what we can do more and better on that regional footprint.
Thank you, Rachel. Will, do you want to, think we should wind up and move on? Do you want to finish?
Yeah, sorry, I just want to thank Sarah and Leanne first of all for that, because that was fantastic.
Really good. Yeah.
And I just wanted to say a few things, just building on Gavin's point about linking it to our strategy, because we've got quite a significant bold ambition here, which aligns to what has been set out. And I think the reflection about actually this is a massive amount has been done, but in a very difficult context. And I don't want to underestimate that. I also want to link it to our joint commitments, because actually part of this is about the sharing and the learning and sharing sort of innovation, and actually this is innovation in a different space, but it's also connecting it to, and could you hear it? You heard it in that presentation. You know, we've set out some joint commitments to be bold and collaborative in our leadership. You heard that. Actually, it was fundamental in as part of that success. What I also heard was actually thinking about how we use our resources differently. So there was definitely a sort of redistributing of resources, and actually that's part of the being bold and doing things differently, because it might have been against the odds. It's also about being really joined up as well. That's something that, you know, you're absolutely really connecting and thinking about that whole sort of journey for our people, but also it's about connecting with our community as well. These are all things that we've committed to, and this is a fantastic example of how we're doing that. The reason why I wanted to come in is because we're going to have to work really, really, really hard, as Leanne and Sarah pointed out, to really get to our bold ambition, and that will take us, you know, that will mean we'll have to be even bolder and work differently. So Richard's reflecting on how we're thinking about how we do some of that across South Yorkshire, so we can really industrialise this. You know, thinking about all those other people that we touch on in our acute setting. Leanne's thinking about how we really maximise the collaboration piece elsewhere. So I just, you know, in the context of what's going on, as Greg points out, we've really got to grab a hold of the opportunity. Thank you.
Adrian, you want to... Thanks, yeah, thanks, Chair. First of all, I want to support Gavin and his CVS. I think they have a big role to play going forward. But the other one is the primary care side of things. Richard mentioned the acute care that's happening in the hospital and the engagement that's going on with patients that are in the hospital. But there's primary care as well. And I'm thinking, of course, of oral care as well, because, as you know, they're picking up the cancers in the throat and elsewhere in the mouth as a result of the dental visits. I have to say that 40% of the people have not had a visit to a dentist in the last 2 years.
Okay, can I thank you everybody for your work? Sarah Leanne, that was really, really good. It certainly made me think, and I'm sure it made everybody else. So thank you for the work you're doing, and thank you for the presentation. Very broad support here. If there's any detailed work in terms of galvanise that, will you talk to Gavin and I, and we'll help lever that through. But I get a real sense of support for it, so I don't think that's a massive issue. So thank you, really helpful. Greg, thank you for your work on that as well.
So I'm just going to say a couple of words, and I'm going to hand over to Sarah. So we've got a deep dive into innovation and research that follows this meeting. So we'll take it the paper. But I just thought it's an opportunity to say how enthused I am at the partnership working that we've had already in here. There seems to be a bit of a sense of aligning of the stars coming here, and you'll see that later on. So without further ado, I'll pass over to Sarah.
Thanks, David, and hi everyone. I'm Sarah. I'm the Programme Director for the South Yorkshire Innovation Hub, which is a joint role across South Yorkshire ICB and Health Innovation Yorkshire and Humber. I sent a paper in advance with the meeting, and we've got a longer session after this to talk in more detail. So I'm not going to talk at length now. I'm just going to summarise a few key points that were set out in that paper by way of framing the conversation we're going to have later. So just if you move to the next slide. I think the key point I really want to make around research and innovation is the fact that it can really help us to deliver against all 4 of the priority aims that have been set out for integrated care systems. We've talked already today, Will, you were mentioning it just then, around the fact we've set ourselves some really bold and ambitious ambitions about the way in which we want to improve care and reduce health inequalities. And we're not going to get there by doing more of the same. It will fundamentally require us to test new things, do things in different ways, evaluate what works and apply evidence into practice. And all of those things have innovation and research at their heart. We've heard that as a kind of living example this morning already around smoking. But I think what's often missed in the conversation around innovation and research is also the opportunity we have for innovation to help drive social and economic development, and that 4th goal that we have as an integrated care system. We'll talk more today about the fact that we've got a really rich set of assets and talents in South Yorkshire that mean health and care and health and wellbeing sector is a real route for creating great quality jobs in the region too. And so if we can act collectively to take advantage of that opportunity, we've got a real there's a real asset here for innovation to drive some of that progress on outcomes that we're looking for. So if you go to the next slide, just a variety of different images on the screen here to give a flavour of some of the strengths and assets we've got in the region. So we've got 2 world-renowned academic institutions who are recognised for their leadership through from early stage biomedical research to manufacturing, production and development of new technologies, and then into the real world evaluation of change on the ground. And all of those are massive assets for us as a system to use and apply some of that expertise into practice. We've also got some specific kind of depth of expertise in areas like children and young people's health and medical technologies to support them, and in mental health. We're seeing lots of new investment coming into the region to support us to grow and develop on those existing ambitions. For example, with the digital health hub that will be based at the Olympic Legacy Park as a joint partnership between the 2 universities, and some new health tech research centres focused on children, young people and on long-term conditions. So we're really leveraging additional investment and growth into the region through some of the existing skills that we've got. And I think one of the questions for us as a collective and as a board is how can we really bang the drum for those skills and talents that we've got, help bring more of that investment into South Yorkshire, but also to use the insights and the innovation that's developed here in our practice, and make sure our population benefit from that equally. On the next slide, please. In light of that opportunity, we've been doing quite a bit of work over the last sort of 6 months or so with many different partners across South Yorkshire to say, well, what does it look like to really act as a system? What's the opportunity for us to add value here? And you'll see on the slide here some of the early goals that we've arrived at that kind of frame what we think the opportunity is for collaboration and working in a more coherent way with a South Yorkshire voice and a South Yorkshire focus on innovation and research. I'm not going to speak to all of them, but I just wanted to pick out a couple of key themes. One is about how we really tie the investment in partnership and development and networking around our integrated care priorities. So really making sure that innovation and research are not shiny and interesting things that we do around the edges of our priorities, but are fundamental tools to deliver on the things we've already said are most important to us and our population. The second, as we've already mentioned, is about how we get new investment to help us go further and faster on some of the things that we care about. And the third is around inclusivity, diversity and equity, which I think are really important principles to guide the way in which we think about growing our innovation and research activity as a collective. We know that often technological innovation can risk exacerbating inequalities, and lots of the work really that we need to do as a system is about making sure that we close the gap through innovation rather than widen it more broadly. So on the next slide, you'll see a few highlights of some of the work we've got underway in light of those goals. And we could talk at length about the different things we've got going on, so I'm not going to do that now. But a few key things to highlight. The first is that we're starting to bring partners together much more regularly and effectively around some of our shared priorities from across academia, industry and health and care partners, so that there's greater visibility of the challenges that we face, there's greater awareness and socialising of the latest evidence and innovative practice that we could learn from, and that there's opportunity for new collaborations and partnerships to develop. We've attracted funding into the system, for example, by working with the VCSE Alliance to take forward a programme of work that will be investing money in voluntary and community sector partners to address inequalities in research participation, so that we're really making sure that health and care research reflects the diversity of our population. And all of that funding is going into our voluntary and community sector partners, because we recognise they're the ones that have the really close relationships with our communities and can help us bridge some of those gaps. We've secured large amounts of funding as well, aligned to our integrated care strategy priorities, to help us adopt proven technologies that can help us do things like better care for young people in our communities, and close inequalities in the care that we provide. So that's all really positive, and I think a recognition of the coherence that our strategy is giving us, but also the opportunity of working more effectively in partnership. So just to my final slide then, I think the key message really to highlight, and we'll talk about this more at length over the course of this morning, is that if we really embrace the opportunities that innovation and research provide us, we can not only use the latest evidence, new technologies, different ways of working to drive forward improvements in health and care, but we can also use that as a tool to support economic growth in the region, leverage new investment, new jobs, and the growth of our economy, which will in turn sort of influence those wider determinants of health. So we should see health and care innovation as a sector of growth and opportunity for us as a region, for health outcomes more broadly. So those are my key points. If I missed anything that you want to kind of emphasise, but we'll talk about it more as we go this morning. Yeah.
A couple of things I might say. Firstly, as someone who came to South Yorkshire quite new, 2 or 3 years ago, in case you didn't get the accent, by the way, I don't think we punch our weight anywhere near enough. And that includes, we don't tell people what we're doing that's really good. And this is an area where we should do more on that. Because when we talk about how we attract national money in and politics, actually talking about how some of the good work you do really does matter. And I genuinely don't think in a whole host of sectors across South Yorkshire, we've done anywhere near enough on that. This is a really good area to start pushing that heavily, I think, because there is some really good work going on. I still worry that we don't punch enough. So that's something for me about a theme for the future. Stephen, you wanted to say something?
And I will say other things in the development session, but I mean, I'd just like to thank Sarah and Dave for bringing this paper forward, because I think it is a significant piece of work that the ICP should be engaged in for the reasons that you've alluded to and what Sarah's just described. It is, and I come from the other side of the Pennines as well, so I've got a better accent than you. But when I came into South Yorkshire, I didn't realise the scale and the world-class nature of the work that goes on around here, and actually it's something to capitalise upon. You know, you read the major condition strategy, you read the IC strategy. We know we've got to do something that is of step change, and the step change exists in certain spaces, but this is one of them. And we need to really sort of sweat this asset in terms of what we've got. You know, it's £3.3 billion of GVA. It's 1 in 6 jobs in terms of health and wellbeing sector. It's something.
Killing my stats for later.
All right, it's some enormous sector, but there's so much here that's opportunity, but we need to deliver it at an industrial scale, and we need to seize the opportunities that exist, not just through Sarah's presentation, but through other bits of the system. For example, the emerging investment zone, the sorts of funding that comes out of that. And if we can synergize all this together, then we're into a really superb space where we're driving growth in terms of what you said, but we're actually driving health improvement as well. So it's a massive space for this board.
Yeah, thanks. Ruth Smith, Consultant for Public Health in the MCA. I just wanted to also just flag that I think this is brilliant, but we also need to make sure that some of the jobs and the skills and all of those gaps we generate through this are for local people, and we're not just importing people from outside. So how do the communities in the areas that these innovative spaces are taking place benefiting in terms of their job opportunities and their prospects as well? So I just think we need to kind of be mindful of that.
Thank you. Anyway, I'll finish that conversation there because I think we do need to move on and we've got a session on it later. And we've now got, Will, you're going to do a report on the exec group? Yeah.
If I could just pick up just three things. I appreciate the time. Operational groups really getting to, I think it's really starting to gel now. I think you can see that in terms of some of the work and the sort of learning that's coming through. Just the three things I just wanted to highlight was we've been having quite a bit of thought about the bold ambitions and how we bring together collective leadership to support that. You know, previously that we've been trying to make sure that that's married up with, you know, folks who are already active in this space. So in the paper that's gone round, there is a proposal around that. I'll beg forgiveness as well, because actually folks, through good intention, have tried to have some conversations up front, but apologies if not all of those conversations have been had. But just gives a really good sense of how we're already starting to work really well together across all of the bold ambitions. Just in terms of feedback, just to feedback either to Marianne, myself or Kathy in terms of any sort of questions, concerns around some of that. And I think the next thing is actually to support those groups to come together where that's needed, because we recognise that already it's already happening. So Children Young People's Alliance, for example, there's already some active space around that. The second thing was just to update on, we had a conversation around how we start to sort of galvanise our resource around this, our people stuff, and the approach that we've taken, which is to try and really sort of pull together who are, you know, folks that are already working in this space. That's starting to work, I think, now. Starting to work really well, and it's really starting to support the engagement with our health and wellbeing boards as well, and that real connect back into our places. So just wanted to update on that. And then the final thing, which is a bit of a signpost really to January, is the Think, Act and Do tanks, which really connect with our joint commitments. Is we've been doing some thinking as an op group in terms of really starting to tease out what we think they are about and what they will do, and watch this space. So we're going to dedicate the January informal to that, and I think part of that will be sort of really refreshing ourselves with our thinking that we had when we developed the strategy. But I don't want folks thinking that there isn't any activity in that space. So as you can see, we're already trying to sort of make sure that they're meshing that in.
Just before you, Kathy, Greg, I didn't realise you had your hand up. I apologise. And then Kathy, I'm sorry. You're now silent, Greg.
Thank you. So don't like to be silent. Very quick one. I'll miss the development session because I'm obviously not there, so I'll get kicked out. So Sarah, I'll pick this up afterwards. Definitely great paper. Definitely agree we don't punch weight. To speak heretical, I'm sort of always nervous about kind of commitment to implement innovation in practice at any cost. Many medtech and life sciences innovations are over and probably beyond the diminishing marginal returns curve, and we forget social and well-being innovations at great peril whilst we focus on medtech and life sciences, etc. So just a word of caution on that one, please. Sorry to be a bit heretical.
Hardly heretical, but it's nice to have you being cautious. Kathy.
It's just a quick thought on the Think, Test, Do tanks. And, you know, Greg mentioned earlier test and learn groups, and maybe we simplify those and call them test and learn, because I think that's a more accessible concept. And I think there's a direct line of sight between the development session we're doing this afternoon and then how we pick up that idea about how collectively we do things differently in the new year.
Thank you. Thanks for that, Will. So we will finish the meeting now. Thank you, everybody. Thank you for those who joined online. We have a development session at 11 o'clock. As I said, I want you to clear the room. I could be ruder if you're not cleared in a couple of minutes. Completely out. There is some tea and coffee in the corridor to attract you there whilst we rearrange the room. Thank you for your time, everybody. Nice to see you.